Good morning, good afternoon, and good evening, everyone. Thank you so much for joining us for this health talk. Welcome. My name is Dr. Tom Fried, and I'm President and Chief Executive of Resolve to Save Lives. We're really delighted that you've joined us for an exciting webinar on game-changing solutions for sodium reduction. I would have to say that sodium reduction must be one of the most important and under-addressed problems in public health globally. There's unequivocal evidence that sodium reduction will reduce blood pressure and therefore reduce heart attacks, strokes, kidney failure, and other problems. We also know that solutions exist that can help prevent the devastating consequences of the excess sodium environment that we live in. They can help us reach the global target. Later this fall, countries around the world will gather at the UN Food Systems Summit for the purpose of transforming the way the world produces, consumes, and thinks about food. Many solutions have been identified that can reduce sodium intake, and these have been incorporated into a proposed list of game-changing solutions for the summit. Resolve to Save Lives, the World Health Organization, and other partners have developed technical tools to support these strategies. Today's webinar will provide an overview of the various game-changing solutions to advance sodium reduction and review tools available to support countries implementing sodium reduction policies and programs, including the launch of the really exciting new WHO Sodium Country Scorecard. We'll also hear from 3 countries who have experience implementing these game-changing solutions for sodium reduction. Now, before I introduce my good friend, Dr. Francesco Branca, I just want to say very clearly that we're not making enough progress in sodium reduction. And the result is literally millions of heart attacks, strokes, and deaths each year that are preventable. Sodium reduction is one of those few programs which is not only cost effective, but even cost saving. We can reduce costs on the healthcare system by reducing sodium consumption. We have a growing body of evidence for what works. Now the challenge for all of us is to implement those proven strategies. And doing so, I think we'll identify countries that are at the forefront of sodium reduction and learn lessons from each other and with each other and be able to really trigger global progress in an area that has not seen enough progress for many years. And now I'd like to turn it over to Dr. Francesco Branca, who is Director of the Department of Nutrition and Food Safety at the World Health Organization and a really wonderful public health leader. Francesco, over to you.
Thank you very much, Tom, and thank you really for the great partnership that WHO and Resolve to Save Life have been building in these years. So good morning, good afternoon, good evening to all. And thank you for joining this webinar on game-changing solutions for sodium reduction hosted by Resolve to Save Life and WHO. And as Dr. Frieden was saying, really sodium is a leading dietary risk factor for an estimated 11 million deaths globally that are associated with poor diet each year. Policies to reduce population sodium intake have been identified as an action that should be undertaken immediately to produce accelerated results in terms of life saved, disease prevented, and cost avoided. In 2013, member states adopted the Global Action Plan for the Prevention and Control of Non-Communicable Diseases 2013-2020. Now the plan has been expanded until 2030 to take coordinated action at all levels to attain 9 voluntary global targets, including a 30% relative reduction in mean population intake of sodium by the year 2025, with a goal of less than 5 grams of salt, which is less than 2 grams of sodium per day. But we're not on track. We're currently not on track to meet this goal, and we need to scale up. To assist member states, WHO and partners have launched a number of tools to accelerate sodium reduction, including the WHO Best Buys, which identifies sodium reduction as one of the most affordable, cost-effective, and high-impact actions for global public health, yielding an estimated return on investment of $13 to $78 for each dollar invested in this program. The Shake Technical Package for Sodium Reduction, recently the WHO Global Sodium Benchmarks for different food categories, and an action framework for developing and implementing public food procurement and service policies for a healthy diet. Today, we're excited to launch WHO's most recent tool, a sodium country scorecard, as part of the database of the global database on the implementation of nutrition action, which we friendly call GINA, which depicts whether countries have set policy goals and adopted voluntary and mandatory measures to reduce sodium intake. This information is key not only for monitoring and identifying areas for targeted action, but will feed directly into the Food Systems Summit, which encourages engagement in a fully cross-cutting approach to nutrition. This single platform for sharing standardized information on sodium reduction policies and action will enable monitoring of global progress in implementing legislative and other measures to reduce sodium intake and increase accountability towards policy commitments. Moving forward, it is anticipated that the sodium scorecard will be the key tool for monitoring progress on a continuous basis towards the full implementation of best practice policies and documented population sodium intake. WHO looks forward to working closely with member states and partners to update this tool and together to reach the goal of reducing population dietary intake of sodium. And with that, I will turn back to Dr. Frieden. Thank you, Tom.
Thank you very much. At this point, what I'd like to do is go through a quick presentation to outline some of the absolute effective evidence-based tools recommended by the World Health Organization, which can support sodium reduction globally. Next slide, please. Excess salt intake increases blood pressure. Nearly all adults in the world are above the WHO recommendation of 5 grams of salt per day. Next, please. It's estimated that about 1.6 million lives could be saved each year by reducing sodium by 30%. This prevents hypertension among children and adults, and it reduces blood pressure and prevents heart attacks and strokes among adults with high blood pressure. This is an enormously important and effective intervention. Next, please. Intervention strategies depend on the sources of salt. For packaged food in largely industrialized countries, industrial reformulation, front-of-pack warning labels, marketing restrictions, and fiscal policies can all be effective. And we've seen this, for example, in the United Kingdom, in Chile, in other countries in Latin America, South America. Second, in away from home food, that is street food or restaurant food. Public food procurement policies, interventions that address restaurants and vendors. And third, home interventions, behavior change campaigns and mass media, and promotion of low sodium and other salt substitutes. Next, please. Industry reformulation, that first strategy mentioned, which is, as many of them are, WHO identified best buys, is a process where the government sets salt reduction targets for key food categories. This might be, for example, a 25% reduction over 5 years. It's better to make these mandatory than voluntary. Frankly, in the US, we've tried for 40 or 50 years for voluntary change, and we've gotten no good results. And that's the general experience in most countries. But it's important to set these targets with industry input, understanding that at the outset, industry may say impossible, but once the targets are set, they say, yeah, it was pretty easy. This is based on the salt content of the category. Monitoring is crucial, and this requires a database and public reporting. There's an opportunity to adapt the WHO global sodium benchmarks to the local or country experience. What we find when we look at foods within a certain category, as you can see from this chart, is that some products are much lower in sodium than others, and they sell just as well. We also know that if we look across countries, there are products that are much lower in sodium than others that do perfectly well. So it's possible to reduce sodium. What we generally find is about 20% in almost any product nobody notices. Beyond that, a gradual reduction can result in an adaptation of our taste preferences. Next, please. Here are two models for industry reformulation. In the United Kingdom, there were voluntary targets for 85 categories. Salt intake fell by 15%. The government was committed, there was monitoring, there was industry reluctant, but existing cooperation and engagement. There were complementary activities such as labeling and campaigns and academic centers monitoring. In Argentina, there were mandatory requirements. Voluntary targets started in 2009, and that had some impact on salt. Mandatory salt limits were set for 18 categories, and in fact, most had met those goals. The concerns were that the limits were too high, not ambitious enough in terms of progress, and covered too few foods. The impact on salt intake was not evaluated, but it's an important program to have done. Next slide, please. Front of pack warning labels. This was really pioneered in Chile, and Mexico, Peru, Uruguay, and Israel have now done similar things. This drives consumers to make healthier choices and avoid unhealthy products. It promotes industry reformulation to meet standards, and it's shown that producers reformulate so they don't have to put these black marks on their products. A black stop sign is very, very clear. We'd like to think, some of us in public health, that people are going to pick up a package and consider it and read it carefully. People spend a couple of seconds. And so if it doesn't have this kind of a clear warning label on the front, it's not likely to have a significant impact on consumption patterns. Similarly, having a low sodium aisle or brand of food is not likely to change the overall sodium intake of the population. So this kind of warning is definitely a best practice. It changes the options that companies deliver to consumers and the choices that consumers make. Next slide, please. Marketing restrictions can also be very effective. Governments can restrict exposure to advertising, promotion, and sponsorship, particularly children under 18, understanding that children see media at all times of the day and night. And these can easily be tied to warning labels. In Chile, the law restricted any ability to appeal to children using brand characters, toys, or giveaways, or child-targeted graphic style advertising on TV programs and websites targeting kids. This is an important way. This was extended to all TV and cinema from 6 a.m. to 10 p.m. because it was seen that it was easy for the producers to get around some of these restrictions. Next, please. Fiscal policies are a promising new area to consider. They've not been done much. Hungary and Mexico had programs. One thing that clearly works is taxes on sugar-sweetened beverages. We know that sugar-sweetened beverages are highly price sensitive, and these taxes should be per amount of sugar or per ounce, what's called a specific tax, not an ad valorem tax, not a percent tax. If you have a 10, 20, or 30% tax, you're just encouraging companies to sell big, cheap bottles of sugary drink. This can be expanded to increase the price of ultra-processed food that's high in sugar, salt, or fat, discouraging consumption. Mexico had an 8% tax on non-essential foods, including salty snacks. That resulted in a 6% decrease in purchases. That's a very high, what's called price elasticity. In other words, these are very price elastic products. So a little taxation goes a long way to make a healthier diet. In Hungary, a 4% tax led to a 3% reduction. So very similar, very high, about 0.7, 0.8 negative price elasticity. Next slide, please. Healthy food procurement is also extremely important. Anything that government buys, subsidizes, or allows to be sold on its property can be made much healthier. No trans fat, lower sodium, sugar, and saturated fat, higher fruit, vegetables, whole grains, availability of clean water. And this can be everywhere the government touches: hospitals, schools, childcare, military, prisons, feeding programs, senior programs, cafeterias, canteens, kiosks. Lots of opportunities here. This is not easy, but it's the least hard of all of the nutrition interventions that can have a really big impact on hundreds of millions or billions of meals per year. Next, please. It also sends a signal to industry and to private businesses of what they might do for their workforce. Low sodium salt is an exciting additional way to possibly make more progress. Replaces between 10 and 30 or 40% of the sodium in salt with potassium, reduces blood pressure. We know that subsidies that equalize the price of regular salt and low sodium salt make a big difference. Promotion can increase awareness and use, and distribution is important to make these available in the market. Next, please. Behavior change communication, or mass media, can make a big difference, disseminating well-defined, proven, behaviorally focused messages to big audiences like TV, radio, outdoor, billboards, posters, and others. It's a scalable educational approach, but it's really either most likely to be useful or only useful if it's combined with other approaches, such as targets or labeling or restrictions on sale. Next, please. From Resolve to Save Lives, we have some new tools on sodium reduction, a sodium reduction course from the Johns Hopkins Bloomberg School of Public Health, 9-module outline, and upcoming sodium reduction framework, which will summarize key recommended components and which we anticipate launching in early August. I think that's the last slide. Next, please. Thank you very much, and I'm looking forward to the discussion. At this point, I will introduce, I believe it is, are we going to WHO or to Jen? Kaya, we're going to you?
Yes, over to Kaya.
To discuss WHO tools for sodium reduction. Thank you.
Thank you very much for that introduction. So my name is Kaya Engesven, and together with my colleague Rain Yamamoto, we will present 4 WHO tools for sodium reduction. So next slide, please. So the first one out of the 4 tools, which we are very pleased to launch here today, is the Sodium Country Scorecard. This is a new feature on the GINA database that allows dynamic tracking of policy progress towards sodium reduction. In the scorecard, countries are scored based on the data that we have on their policies and actions to reflect their policy progress. The first score implies that there is an expressed commitment in national policies to reduce sodium intake. For example, a goal to reduce it by 30% in a national NCD strategy. The second score is given to countries with voluntary measures for sodium reduction, such as a voluntary front-to-pack labeling scheme or marketing restrictions that include sodium in their underlying nutrient profile models. The third score is given to countries that have mandatory declaration of sodium on all prepackaged food and also implement at least one mandatory measure that includes sodium in its underlying nutrient profile model. For example, mandatory reformulation, sodium tax, or compulsory school food standards. The fourth score is given to countries with at least 2 such mandatory measures and at the same time are implementing all the sodium-related WHO best buys. So in the scorecard, by clicking on a country in the table below the map, you can access the specific policies and action data which were used to calculate the score. And from those data, you can click your way further into GINA to access other food and nutrition policy data available in the country. Above the map, there is a population count, which is depicting the percentage of the total population that is covered by mandatory sodium reduction measures. So in other words, the share of the world's population living in countries with scores 3 or 4. We are also exploring inclusion of complementary information on strategies that are crucial for successful sodium reduction policies, such as surveillance of sodium intake in countries. Now, the Sodium Country Scorecard will be continuously updated, and we are adding information as it becomes available. So in particular, we'd be very happy to receive information on country policies from all of you to help us keep this tool updated. Next slide, please.
Kaya, I'm sorry. Somebody noticed that your voice doesn't come very strong. So can you come closer to the microphone, please?
Okay, thank you. Yeah, so just for those of you who may not be familiar with GINA, this is the WHO database on national nutrition policies and actions, which is used for a range of reporting purposes. The online platform, as we know it today, it was launched in 2012, but it actually reflects and incorporates WHO nutrition policy monitoring work over 3 decades. Next slide, please. Most of the data in GINA come from WHO policy monitoring work, but we also collaborate with partners and incorporate their data. In GINA, we also have a wiki approach feature where registered users may contribute data, which is then later verified by WHO before it's published. Next slide, please. The second tool that I will talk about is the SHAKE package. It was designed to assist countries with developing, implementing, and monitoring salt reduction strategies. The SHAKE package outlines the policies and interventions which have proved to be effective in reducing population salt intake, and it provides evidence of the efficacy of the recommended interventions and also includes a toolkit which contains the resources to assist countries to implement these interventions. SHAKE covers 5 strategic actions, including surveillance, harnessing the industry, adopting standards, knowledge, and environment, and it focuses on the WHO sodium-related best buys. So in WHO, we will be revising the current SHAKE package this year to update it with the latest science, tools, and experiences. Next slide, please. The third tool that I will talk about is the WHO Action Framework for Developing and Implementing Healthy Public Food Procurement and Service Policies, which we launched in January this year. This is a tool for countries that want to develop policies to ensure that the foods and beverages served or sold in public settings or procured with government funds aligned with healthy diet principles. The action framework provides guidance, resources, and tools around the steps of the policy cycle. And if you want to learn more about this tool, you can access the launch event in the 6 UN languages on the link that is provided. I will now hand over to Rein Yamamoto for presenting the 4th WHO sodium reduction tool here today. Thank you, and over to you, Rein.
Thank you very much, Kaya. So I'm going to talk, next slide, please. Yes, thank you. The Global Sodium Benchmarks is a brand new tool for reformulation. We just released exactly a month ago, and I actually put the link to this document in the chat, so please check that out. So the Global Sodium Benchmarks are the maximum limit for the amount of sodium that a processed food can contain, and they are a harmonized global goal. This is really important, as mentioned by Tom, because oftentimes similar processed foods contain different amounts of sodium in different countries. So we really want to eliminate this regional disparity so that all countries can equally benefit from foods with lower sodium. Third, they are a guide for countries, and we encourage countries to adopt the global sodium benchmarks, which helps them establish their own national targets. Fourth, global sodium benchmarks serve as a basis for dialogue with industry. We need industry to implement the global sodium benchmarks to reformulate their products. Finally, global sodium benchmarks are established for 64 priority food categories, which are commonly consumed major contributors to sodium intakes. Next slide, please. So here you can see just several examples of the global sodium benchmarks. For example, for bread at the top left, the leavened bread, the benchmark is set at 330 milligram of sodium per 100 gram of product. We set the benchmarks by collecting data from 41 countries and 2 regions, which have already set sodium targets. So in principle, the lowest value of the existing national targets was chosen for each food category. And yes, these targets are challenging because they are the lowest of the existing national targets, but we know these benchmarks are feasible. Feasibility has been demonstrated in a number of countries, and we believe these targets can be implemented in other countries as well. And In fact, we are going to release a new tool soon, which is a step-by-step guide for countries on how to implement the global sodium benchmarks. So please stay tuned. And that's it from us, WHO. Thank you very much. And now I'm handing over to Jennifer Cohn, the Senior Vice President, Cardiovascular Health at Resolve to Save Lives. Jen, over to you.
Great. Thanks so much, Ryan and Kaya. So we've gathered a really exciting group of presenters to share their experiences implementing game-changing solutions for sodium reduction. The presenters today will include Ma-Ann Rosales Santo Domingo from Imagine Law in the Philippines, Eduardo Nilsson from the Ministry of Health in Brazil, and Renu Garg from the WHO Thailand office. For those of you attending live on Zoom, please enter any questions for our presenters by using the Q&A feature at the bottom of your screen. We'll first be starting with a presentation from Ma-Ann on their project to develop a healthy public food procurement policy. Ma-Ann, please go ahead.
Hi. Good morning, good evening, everyone. We're very happy to be here. And I'm very excited to share the work that we have been doing in the Philippines. So Imagine Law, our organization, is a public interest law organization. And for the past year, we've been working with the biggest city in Metro Manila, Quezon City, working on reducing sodium consumption and improving healthy diet and nutrition in general. So let me begin with this. My presentation is entitled No Public Funds for Unhealthy Food. And really, this is a statement from the Quezon City Mayor. Next slide, please. When she approved the Healthy Public Food Procurement Policy of Quezon City last month. And she said that no public funds will be spent on unhealthy food. Words are powerful, as you know, and it inspires all of us. And because this means that all procured food served by the Quezon City government to its beneficiaries will have to pass a nutrition criteria, which includes a limit on sodium content. But how did we get here? So let me walk you through, in this very quick presentation, our journey over the past year. Next slide, please. So first, we defined the problem. How big is the problem? We knew that cardiovascular disease is the #1 killer in the Philippines. And we knew that the burden of unhealthy diets is really weighs heavy on all countries around the world. But how big is the problem really? So based on 2020 data from the Philippine Statistics Authority, almost 100,000 cardiovascular deaths annually has been recorded. So that means that we've been losing 11 Filipinos every hour and 273 Filipinos every day. So that would mean that by the end of this dialogue, 11 Filipinos would have died from cardiovascular death. And where does sodium play in all this? Sodium and salt intake, based on the Philippine NCD investment case conducted by the World Health Organization and UNDP. Sodium consumption is estimated at 4.29 grams per day in the Philippines, which is more than twice the WHO recommended limit of less than 2 grams per day. And 28% of cardiovascular deaths are directly linked to high sodium intake. Next slide, please. But we wanted to approach the problem holistically, and we looked at unhealthy diets as a whole. So what is the burden of unhealthy diets? It's 11 million deaths globally every year, and that means 1 in every 5 deaths, which means also that if you're in a household of 5 people, 1 out of your family members or loved ones would have died from the risk factor of unhealthy diet. And the culprit is poor diets high in sodium and low in whole grains and fruits. Next slide, please. So what did we do now that we knew the problem? What was the intervention that we have identified? We chose to advocate for a healthy public food procurement policy. We recognize the government's role and unique responsibility to provide food that is nourishing, that is life-giving, and does not contribute to disease. So we approached Quezon City because local government units provide basic services such as food provisions. And we developed over the past year a nutrition criteria that will set a standard for all procured food. Here you will see our key nutrition guidelines, which is anchored on national and global dietary guidelines. In particular, the Philippine Dietary Recommended Intake and WHO's 5 keys to a healthy diet. Here you will also note that under item 6, sodium or salt is limited. Next slide, please. Particularly on salt and sodium, for prepackaged food, we limited sodium content to less than 120 milligrams per 100 grams of the product, which is the threshold for low sodium content as defined by the Codex Commission. And here you will also see that fats and sugar are also limited, and trans fat in particular is restricted or not allowed to be present in prepackaged food. How do we monitor? We look at the nutrition label to be able to assess whether prepackaged food that is procured by the government passes the nutrition criteria. Next slide, please. Now, for unpackaged food, such as baked goods from local bakeries, fried food, and local delicacies, we provided a guideline for food preparers or food suppliers to use less salt, less sugar, and less fat. And if adding salt would be unavoidable, they are advised to use iodized salt. Next slide, please. Other salient features of the policy provided that an expert group is convened as assessors for whether the food that has been procured passes the nutrition criteria. So this means that nutritionist dietitians from the city's health department would be part of an assessment committee to be able to determine that food that has been bought and will be served to beneficiaries will pass this criteria. They will be using a scorecard to be able to determine whether the content of prepackaged food and unpackaged food passes the criteria. We also were very cognizant of the fact that improving diet does not exist in a vacuum. We exist in an ecosystem of different issues and concerns, and we wanted to make sure that we fostered a healthy and sustainable food system. So the policy in itself also included mechanisms for supporting food suppliers, for ensuring local sourcing of whole food, for providing incentives to micro, small, and medium enterprises. This here on your screen, you'll see Grow QC, which is a sticker stamped on the squash here. Grow QC is also a program of the Quezon City government that promotes urban farming. So we're trying to link together all of these initiatives that will provide a sustainable food system for the city. Next slide, please. So how did we do it? Last year has been very challenging for everyone, and amidst a global pandemic, facing restrictions on face-to-face engagements, in-person events or trainings, we had to be very creative, and we anchored our strategies on these 3 pillars. We ensured that there is in-depth research and assessment. We made sure that we implemented open and inclusive policymaking, and we also made sure that we had close engagement with multi-sectoral stakeholders ranging from the city officers and also food suppliers that provide food to the city government. Next slide, please. So how do we intend to sustain this momentum and scale up? We have deliberately lined up the path towards scaling up this policy. We are currently conducting trainings for kitchen staff and food suppliers. I'll talk more about that in a bit. And we're also developing complementary tools that could be replicated in other cities and municipalities in the Philippines. We're developing a healthy cookbook, a healthy menu, a healthy directory of food suppliers, and scorecards for assessment and monitoring. We will also be piloting and evaluating within the next 3 to 4 weeks the impact of incorporating these nutrition standards in food preparation in Quezon City. And lastly, we're looking to scale it up to become a model policy for all local government units in the Philippines and for implementation as well in national government agencies. Next slide, please. So let me end with this. I started with a statement from Mayor Belmonte, and I'm ending with this. This is a photo of our training yesterday, where we trained 100 kitchen cooks and staff. And if you zoom in here, you will see that most of them, in one Zoom account, there are about 10 to 12 kitchen cooks and staff and food preparers in Quezon City. And what I want to say is that we can't, as Tom mentioned earlier, it's not easy. We're in fact, we're perhaps a bit delayed in our work in reducing sodium intake, but we have to take the first step. And it's always been about people, these people who are willing to take the first step with us. So it's our hope that, like Quezon City, all the cities in the Philippines, all the cities in the world would be able to say that no public funds shall be spent on unhealthy food. So thank you very much, and over to you again. Thank you.
Wonderful. That was really compelling, Ryan. We'll next move to Eduardo Nilsson from the Ministry of Health of Brazil. Eduardo, over to you.
Oh, thank you very much for the opportunity. Good afternoon, good morning, good afternoon, good evening to all. And I'm delighted to speak about the country experience of Brazil in sodium reduction. So next slide, please. Firstly, I'd like to stress the burden of all dietary risk factors, but especially high consumption of sodium. And we have estimates that over 40,000 deaths by cardiovascular disease yearly in Brazil attributable to excessive sodium consumption. And that also means many costs to the health system, close to $200 million per year, and costs to the economy. So it makes it a very strong case, as Dr. Friedman has said before. Next, please. And we are facing a very big challenge, because we have almost twice the recommendations of WHO. We have 9.3 grams of salt per day in terms of urinary excretion, and there are multiple dietary sources of sodium, which in first place are table salts and salt-based consumption, salt-based condiments, which roughly half in terms of these 64% of salt in diets. And we also have a large share, an increasing share of processed and ultra-processed foods, industrialized foods, and also, of course, the naturally present sodium in foods. Next, please. And this all requires, of course, many strategies to tackle that, and along with that, many changes in diet. So we have an increasing participation of ultra-processed and processed foods in diets. And along with that, we're seeing it's replacing the regular meals. And that means that even table salt and salt-based condiments are being reduced over time. So here I'm showing that 17% reduction in less than a decade, while there's an 11% increase in terms of the participation and consumption of ultra-processed and processed foods. Next, please. Therefore, we are working on a holistic approach as well. We're starting with reformulation to reduce sodium content in foods through industry commitment in a voluntary approach. We have healthy public food procurement policies, especially school meal programs, school food programs, nutritional labeling, and last but not least, behavior change communication, especially based on the dietary guidelines. Next, please. Now I'll detail a little bit about each of these strategies, starting with the food-based dietary guidelines in Brazil, which are very important for us nationally, but also internationally, because of the message, the prioritization of fresh and minimally processed foods, avoiding ultra-processed foods, and a special message on using small amounts of culinary ingredients, which include salt. And this is used for inducing policies, but also for sending message to the populations, training health professionals. It has been also linked to the the guidelines for children under 2 years of age, of course, emphasizing breastfeeding, complementary feeding, but also the message on ultra-processed foods and other risk factors. And it's still challenging for us, so we're always looking what we have achieved, but also the cup less half empty. So we have to expand behavior change communication, especially using social marketing for inducing these changes in behaviors and knowledge and attitudes. Next, please. So here are some examples of the messages that we have sent over time to the population, emphasizing the messages of the dietary guidelines, especially on using salt, sugars, and fats in small amounts, the risks of excessive sodium, comparing the amount of sugar, of salt that we have in the diet to the WHO recommendations and alternatives in terms of herb salts and other that we can use, the population can use easily for replacing salt in a healthy manner and keeping foods tasty. That's something that we've learned in Latin America in many discussions, is that salt is viewed by the population as making foods not healthy, but tastier. So when you have the use of other condiments, it helps us to keep that in foods. Next, please. And we have also advanced in terms of food labeling. We have in Mercosur with our partner countries, all of the mandatory sodium declaration and the health claims with low sodium have been in place since 2003. And more recently, last year, we had approved this front of pack labeling, which differs a little bit from the ones from Mexico, Chile, and other countries, but it's also a warning system, so that we have a challenge to assess the impact of this different system, and also to expand the food labeling to restaurants and other food services that may benefit in allow the population to have more information on the salt content, and not only salt, of course, sodium, but also other critical nutrients that are related to non-communicable diseases. Next, please. We have worked with foods consumed away from home, and so that means there's an increasing participation of these foods in the diet. We have seen that over time, and we're working with bakeries, with collective restaurants in terms of having guidelines for preparing healthier foods, especially in terms of sodium, but also in terms of sugars and fats. We have many local initiatives as having smaller salt packages, withdrawing salt shakers from tables. And we're working now on this challenge, which is making these successful local initiatives national and setting these targets for restaurant foods, fast food, traditional and artisanal foods. This is very important, not only for Brazil, but many Latin American countries, but I believe in many countries in the world, that we have all this plethora of different foods that are consumed away from home, and we have to tackle them together. Next, please. We have very strong procurement policies. I think that a great example is the National School Food Program, which we have a very strong message in terms of food purchases, in terms of procurement of local family farmers. And there's more recent advances that in alignment with the dietary guidelines that at least 75% of foods must be fresh and minimally processed. And there are also specific nutritional standards, especially applied for sodium in this case, that 400 milligrams per meal up to 1,400 milligrams in terms of the children have 3 or more meals at school. So it makes it very strong in terms of bringing the message, also preparing the taste of tasty foods, but with less salt. And along with that, of course, nutritional education. But we also have a great challenge in terms of advancing in other regulatory policies, and especially in terms of the sales and marketing on healthy foods. That still happens both in private and public schools in the country. Next, please. And finally, I'll speak a little bit about food reformulation, that we have followed much of the steps of the UK, working on a voluntary agreements with Umbrella Association of Industries, which is very beneficial because of the reach it has in terms of the market. We have set maximum sodium content for as targets for foods, and prioritize foods based on their contribution to sodium intake in the population, but also addressing some foods that are mostly consumed by children and adolescents. And based on that, we set these biannual targets, which gradually decrease the maximum levels of target. And it's very important to stress that transparent monitoring is key for that, for keeping the compliance of industry and keeping the momentum. But we, as has been said by WHO and other colleagues, we have the challenge of looking at this future with the new categories, and especially the new benchmarks that's set by other countries, but Pan American Health Organization and WHO right now, until we have to move forward with that. And looking at, as neighbor countries as Argentina, if the voluntary targets will reach a point that they may become mandatory. That's something that's always under discussion, and using data, national data will strengthen that very much as a case. Next, please. So here are some results. As I said, it's showing the cup half full and half empty at the same time. So at the left, we see the percentage of sodium reduction in terms of the average content of sodium in food. So we have reached up to 34% in a specific food category in terms of average reduction in salt, in sodium. But besides that, we see that the regional targets that are set by PAHO, we still have a lot to move forward in terms of many categories. So we're looking at that as something to be addressed in the future as well. Next, please. And here are some results in terms of where it's very important for us to keep track of this, all the changes. And we have, of course, the information from industry, who is a partner in this voluntary approach. And they have this, that 28,000 tons of sodium would be reduced over this strategy that started in 2011. But we had to show that in terms of something that means health outcomes. And that's where it comes. We have this estimate that 0.25 grams per day has been attributable in terms of reduction of salt. Using these targets that we have set right now, but we have already estimated that we have to move forward. And if we apply different targets, more stringent targets, both from other countries and from PAHO, we could reach twice or three times more reduction in food. So that's something we should aim to. But we know that what we're doing has a strong impact, as has been estimated. Up to 2032, we'll have an estimated prevention of postponement of 182,000 CVD cases and 14,000 deaths. So we have to move forward. These are strong numbers, but we need them to be even larger. Next, please. And now I'll speak to finish my conversation about some conclusions and lesson learned. First, it's very important to have multiple strategies to address all of the dietary sodium sources that we have in the country, and that is common not only to Brazil, but many other countries. We have to have strong advocacy, and that is very important. As I said, regional and global committees are very important for that, and using global and local data is very important to also give this advocacy tools. And strong roles of government and also civil society are very important to keep that momentum and that compliance. Using national data is very important for having these tailor-made strategies for countries. So there's not one size fits all, but the major strategies are the same. You have to adapt them to each country, to their realities, and using national data that strengthens. Next, please. And finally, it's very important in terms of engagement and compliance of the private sector, again, to have transparency and impactful criteria for target setting and continuous monitoring to keep that. And also, it's not only for keeping compliance, but also to always aim for the larger health benefits. So resetting targets when necessary to achieve that, and having the benchmarks is very important. That's why I stress the cooperation between countries is very important. Brazil leads a network for action in the Decade of Action on Nutrition for sodium reduction. We have the participation of many American countries. So it's not only Latin American, but Canada participates as well. So it's very important for us to share experiences. We have a common project that was financed by the Canadian IDRC. With many countries, we have helped each other in many aspects, and we keep that momentum going. And of course, the technical support from WHO and regional offices is very key for us. And of course, Resolve to Save Lives as well. And we have this examples of many of the tools, the policy tools, and stressing the importance of the recently launched sodium benchmarks that are very important for all countries. And finally, modeling the impacts is very important as well, because we have to tailor this information for the countries, and that strengthens advocacy and strengthens policy making, evidence-based policy making, especially for fiscal and regulatory policies, because that is where we may have a lot of pushback from many other sectors, especially the private sector. So it moves us forward in showing that it's really safe, cost effective, cost saving, and life saving in the very end. Thank you very much.
Great, thanks so much, Eduardo. I'll now ask Renu Garg from WHO Thailand to speak to their experience.
Thanks, Jen. Hello, everyone. Happy to share lessons from Thailand. And I want to acknowledge the great work of all the sodium champions around the world and in Thailand. Next slide, please. Let me start by saying that food in Thailand has too much sodium. A single meal, whether it comes from a restaurant, street corner, or in packaged meal, can have close to 2,000 milligrams of sodium in a single meal, which is way above what's recommended by Thai guidelines. Next slide, please. Not only is there a lot of sodium in food, but there's also a lot of variability in the amount of sodium in foods in the same category. For example, in this slide, every dot represents sodium content in a packet of noodle, and there are about 248 brands of noodles that are represented here. And you can see that there's a huge variation in the sodium content, which also means that there's a lot of potential to reformulate to lower sodium content. Next slide, please. So there are three main sources of sodium in Thai diet. A third of sodium comes from discretionary use in home cooking. And this comes not only from salt, that's NaCl, but also fish sauce, soy sauce, and bouillon cube is also important, which contains almost 2,000 milligrams of sodium in a single cube. The second source is discretionary use in food cooked in street food and restaurant food, which is also very popular in Thailand. Again, salt and bouillon cube, as well as sauces, but also in street food, there's extensive use of MSG, or monosodium glutamate, which adds the umami flavor. And a third source is packaged food or ready-to-eat meals. And this market is growing at 5 to 10% annually. This is here, salt is added by the food industry, which cannot be taken out. The point I want to highlight is that even in home and street cooking, there's a lot of scope to reformulate, for example, the bouillon cube and also the sauces. Next slide, please. So the sodium reduction movement in Thailand is about 5 years old. There's huge commitment at the national level. There's a national target. There's a solid strategy along the lines of the WHO Shake package. In 2008, the Thai FDA reached an agreement on a voluntary basis with the food industry. And the food industry agreed to reduce sodium by 5% every year. There's also a proposal for sodium taxation. And this is not yet approved, but there's a lot of work that's gone into it. And we think that is a game-changing solution because it can encourage reformulation, it can discourage consumption, it can also be a vehicle for public education, and finally, it can generate resources that can be put back into health promotion. There are many other very good policies and plans in the pipeline, including setting maximum sodium levels. Next slide, please. So like in the Philippines, Thailand also works. In Thailand, a lot of stakeholders work together. The Ministry of Public Health is leading, but the Excise Department is an important partner. So is the Thai FDA. The Thai Health is, which uses taxation on tobacco and alcohol, is putting in a lot of money on sodium reduction. And the driver really is this low salt network from the civil society. So these are all important stakeholders. The food industry is on the table for most of the consultations. I would say in 8 out of 10 consultations, the food industry is allowed to be on the table. Next slide, please. One of the questions that policymakers always ask us, so where is the data from Thailand? So it's really important to have local data, as a colleague from Brazil said. And this is an example of an economic evaluation of sodium reduction policies that are used in Thailand. which shows that all of the policies were cost-saving and life-saving. The top three were health communication, sodium taxation, and mandatory reformulation. Next slide, please. In terms of monitoring, our FETP colleagues have analyzed data between 2015 and 2019 in several products, packaged food. And overall, unfortunately, only a third of the food products were reformulated over this period. And the average reduction in instant foods was only 105 milligrams, which is about 5%. So 5% over 5 years, too little and over too long a period. Next slide, please. So the journey of sodium reduction in Thailand has been bumpy. The main obstacles are interference and delaying tactics by the food industry. There's also a lot of political inertia, administrative inertia. There's hesitancy to take bold decisions. The academia also, there's been too much of a narrative around the importance of sodium as a preservative. So that's also cast some doubts, especially in terms of food safety. Another barrier is that the people don't really appreciate how much sodium they are consuming in a single meal. So public awareness definitely remains an important strategy. Fortunately, we also have a lot of support from champions. They are making all the difference. Funding from Thai Health, which is collected from surcharge on tobacco and alcohol, has been instrumental in conducting surveys as well as funding the public campaign. WHO's presence at the country level and support has also helped to accelerate the movement. And I must also acknowledge the support that Resolve to Save Lives has given, both in terms of catalytic funding, but even more importantly, in technical support, very high quality technical support at supersonic speed. Next slide, please. So this is my last slide, and I want to wrap up by these 5 lessons for countries. You know, there are very good strategies at the global level and at the country level, but how to take it to scale? First is generate local evidence. This is really important, especially to counteract industry-mediated misinformation. Second, go for mandatory reformulation. We started with voluntary, but it didn't really work for us. Mandatory reformulation, we think, is a way to go, and because here the rules will apply to all players equally. Third, get all allies on your side and think out of the box when you think of the allies. Think about affected patients, stroke patients, or patients on dialysis, consumer protection groups, chefs, parents, teachers, even school children. So I think getting all the allies on your side will help to create this big social movement which is required for this. Fourth, you will need funding, especially for example, public campaigns are quite expensive. And taxation of unhealthy products, including taxation of food products with excessive sodium, can be a win-win strategy. And finally, grow the tribe of champions and fully support them. Champions are deeply committed, passionate people who work tirelessly. They keep on pushing the agenda forward against all odds. Champions, I think, make all the difference. And I could talk about it for a long time, but I'll stop here and hand back to Jen. Thank you.
Thank you, Renu, and thanks to all the panelists. That was absolutely fantastic. Unfortunately, because we are basically at time, we'll not have time to take any additional questions, but I've seen there's a very lively question and answer in the Q&A box that the panelists and others have been participating in. So I want to thank all the panelists, thank everyone who's attended, and just wrap up by summarizing a few key points from this session. One, it really seems that multi-component approaches that take into account stakeholders across a food ecology can be very successful and have been very successful, as in the case of the Philippines. Policies, especially mandatory policies, are powerful and can be both sustainable and scalable. And data remains critical. We have to have this data, especially local data, to make sure that our policies are well informed and that we can compel and convince all stakeholders. Targets should be bold, but they should also evolve over time as tastes and industry technology evolves. And we may be able to set lower and more bold targets as we move forward in time. And identifying champions, forming coalitions, and strong evidence-based advocacy are all critical. High sodium consumption is a major threat to the health of populations around the world, but we know that that change is possible. Countries are already implementing the scalable, game-changing solutions that you heard about today, and these strategies are saving lives, building more resilient populations, and bringing us closer to the global target of 5 grams of salt a day. But we know that much more progress is needed, so we look forward to hearing about all the game-changing solutions to reduce sodium consumption that you are planning in your individual geographies. We hope the resources and tools that we shared today will assist you in your sodium reduction efforts, and you can learn more about these tools online by visiting the Health Talks website. The link is in the chat, or will be in the chat. There it is. Nicole posted it, and the resources will be posted immediately following this webinar. So I will close our webinar today. Again, thank you to all the speakers, the panelists, and to all our colleagues that attended. Have a good day.
Thank you. Bye.
Bye.